Welcome, everyone. Have a good evening. My name is Dr. Gary Severance, and I'll be your moderator for tonight. I'm very excited to welcome Lancette VanGuilder, a leading clinician and internationally renowned speaker, for a deep dive into common oral pathologies such as papillomas, tumors, vapor's tongue, and oral manifestations of COVID-19. And she's going to also touch on monkeypox. And now hygienists and how they play a vital role in preventative health care. Before we get started, I would like to take a moment to go over some housekeeping. If you have a question, please type it in the box labeled "Have a Question" on the right side of your screen, and we will answer them live at the end. This webinar is sponsored by Premier Dental. We are also offering CE credit for this webinar. If you are interested, please click on the CE available icon on your screen to fill out the survey required for CE. Lancette, welcome, and thank you for being with us tonight. I'll pass it over to you.
Excellent. Thank you so much. Thank you to Henry Schein for putting on this webinar. It's because of companies like this that we're able to get together and learn in the comfort of our own home and stay up to date on all the new and emerging information that's constantly coming out. So I'm very grateful for Premier Dental Products and Henry Schein for making this all possible. I am a dental hygienist, and I truly believe that the dental hygienist plays a pretty critical role in healthcare just in general. I do think that dental hygienists are superheroes, right? We are elite healthcare providers, and we're clinicians, and we're detectives. We're a teammate to the doctor, and we're an advocate, for our profession and for the patient. My name is Lancette. I am a speaker. I am a clinician in private practice at a Complete Health Dental Center. I am also a clinical director of a sleep and airway center in Reno, Nevada. I am also a COVID-19 vaccinator. I've given just a little over 20,000 COVID vaccines to date, and a really proud public health endorsed dental hygienist. So I own my own mobile dentistry company, and at least one day a week I go and provide free dental services to, on tribal reservations, after school programs, schools, nursing homes, homeless camps, and pretty much wherever they will let me set up my chair that you see over here on the right side. So you can see I'm super passionate about dentistry and healthcare, and I'm really excited to see this new emphasis on medical dental integration. And I think that hygienists are essential primary care providers, and we are an important part of a healthcare team. And we have the opportunity to raise awareness, to provide education and screenings, to provide and promote vaccinations, testing, treatment of diseases, and really, help improve the quality of life for our patients. Because we only have an hour, I'm packing in as much as I possibly can into this content for you. We need all the help we can get, right? We don't get to see pathology a lot, and when we do, I think it's good to have these reminders that as a dental hygienist, your most important role is to tell the patient that you're screening, tell the patient what you see, to document, to assess, and then, transfer this information on to your referral source, whether that's the doctor that you work with or another specialist. And there's really kind of 4 key pillars. What do you see? Where do you see it? Why do you see it? And when did it appear? So today we're going to refresh and review our oral pathology. So here is your first quiz. You don't have to type it in or call in or poll or anything. Just to yourself, do you know how to describe this? Do you know how to describe this rash? This is first signs of an oral rash, and they are flat lesions on the mucous membranes. In this specific case, it's going to progress. But if you were just to describe this, do you remember the medical term for this? This specific rash right here is going to progress to macules, and the macules are going to progress to papules. The papules are going to progress to vesicles. The vesicles are going to progress to pustules, and then the end result will be scabbing and healing, probably over 3 to 4 weeks, this specific case. But some of these rashes may present for something else. The term for this rash is called an anthem, and this is this broad, diffuse rash that's flat, just like you'd see on the skin, but you're seeing it in the mouth. I want to bring this up because this might be the one oral lesion that you see if you are encountering monkeypox in your dental office. chances are you're probably not going to encounter oral lesions or monkeypox in the dental office. And the reason for that being is because people who've been exposed to monkeypox typically feel pretty crappy. They're going to have that fever, that chills, that flu-like symptoms. They're going to have swollen lymph nodes, and they're not going to probably feel like going to their dental appointment. But according to the CDC, monkeypox spreads by close or intimate contact, skin to skin, typically direct contact with body fluids or the rash itself, touching objects like bedding or clothes or towels. However, research is showing that yes, it can also become exposed with respiratory secretions, although that's pretty unlikely. Typically, it's oral, anal, or vaginal sex, or those body parts touching, hugging, kissing, massaging. In fact, I just listened to a really great segment on TV the other day about how we don't really have to probably worry about a monkeypox outbreak at schools, for instance. It is not quick encounters that typically spread monkeypox. It is prolonged face-to-face contact or touching that typically isn't happening in most settings outside of maybe the household. The monkeypox is actually part of the orthopox virus, so it's just like smallpox or cowpox. And guess what? It's mutating, so we have variants, clade 1 and clade 2. The CDC says that in the United States that monkeypox is now our next national public health emergency. And up until this year, pretty much monkeypox was kind of isolated to regional parts of Africa. But in 2022, it spread worldwide, and the U.S. now accounts for 60% of new infections. Monkeypox is not new. However, in 2021, there was actually 2 cases in the United States, but in 2022 alone, there's been 16,000 cases. We're seeing the same kind of beefed up efforts that we saw with COVID, with monkeypox, in awareness, raising awareness, talking about disease prevention, testing, swabbing, vaccines, and antivirals. The really key thing to know about monkeypox is a classic manifestation is a rash on some part of the body, as well as certain lymph nodes, and that certain demographics are more susceptible. In fact, the CDC says that gay, bisexual, or other men who have sex with men make up the vast majority of cases. However, regardless of age or sexual orientation or gender, anybody can become exposed. And even though we've had 16,000 cases in the United States, there has been 0 deaths. So that's great news. We're still on an upward trend, though, that we're seeing new outbreaks happening very, very almost daily. According to the CDC, though, in Africa, about 75% of the cases in Africa, there were oral lesions. The lesions are well circumcised, they're circular, and they're deep-rooted. And some of these lesions will develop this umbilication. You can see the middle of that lesion, that kind of dot on the top. But according to the American Academy of Dermatology in the United States, oral lesions and primary lesions on the face and the mouth have not typically been seen. So the outbreak in the United States, most of the lesions are on the groin, the genitals, or the anus. These are somewhat some of the other monkeypox lesions might look like on the skin or the cheek or around the mouth. Interestingly enough about monkeypox is that you might not have symptoms like a rash or any kind of fever or swollen lymph nodes for 3 weeks after you've already been exposed. That's a long time. Just like I said, fever, chills, headache, muscle aches, swollen lymph nodes, respiratory symptoms, or maybe a rash on the groin or face that start off as a rash and then kind of go through that whole life cycle. This is kind of what some of those monkeypox lesions might look like on the face, and then down on the lower right side of your screen, you'll see one on the gingiva, classic circular raised with that spot in the middle. Pretty distinct looking rash. Shifting gears to kind of another public health crisis that we have is oral cancer. We know statistically that oral cancer is something that is still very, very relevant in our society. Oral cancer kills 1 American every hour, every day, and the numbers are rising. Oral cancer kills as many people as melanoma and is now more common than leukemia. Oral cancer is actually the 6th leading cancer in the world, and anywhere from 65 to 75% of oral cancers are specifically linked to the HPV virus. We know that almost every single one of us has been exposed to the HPV virus, one of them. We most likely didn't even know it. It happened in our teens or 20s. We had an exposure, we got the virus, but we didn't know it. And for 99% of the population, it clears the body within about 18 months. However, for some people, the virus goes dormant, just like other viruses, like cold sores, right? The virus goes dormant and it lays in tissues, typically in the back of the throat. And then decades, 30, 40, 50 years later, it manifests in oropharyngeal cancer. And the HPV is considered to attribute for anywhere from 65 to 75% of mouth and throat cancers in the United States. And the HPV vaccination has shown to possibly prevent more than 90% of cancers caused by the HPV. And the HPV vaccine was approved by the FDA in 2020 to prevent mouth cancer, oral and throat cancer. So dental professionals, we have a super vested interest in recommending the HPV vaccine to our patients because we're typically the only people talking to patients about mouth and throat cancer. Even if somebody does survive oral cancer, it's pretty tragic that they are now 20 times more likely to develop a second type of cancer, anything from lung cancer, colon cancer, cervix cancer, to even another type of oropharyngeal cancer. So I want to look at risk factors just real quick here. Sorry, I guess that slide doesn't want to show, but risk factors for oral cancer, typically have been, exposure to radiation or exposure to ultraviolet light or chronic irritation or alcohol or tobacco. But now we know risk factors for oral cancer include viruses like HPV, probably other viruses that are being looked at right now too, as well as bacteria. Periodontal pathogen, P. gingivalis, is a high-risk periodontal pathogen that's actually highly linked to oropharyngeal cancer. What research don't know is, do the bacteria in our mouth actually cause cancer, or do they just cause the cancer to grow more rapidly? Because we're seeing evidence of P. gingivalis, that periodontal pathogen, in about 12% of the surrounding tissue around throat cancer. So we know that there's a correlation. We just don't know the exact mechanism yet. It's estimated only about half the population goes to the dentist, which is really sad. But again, you might be the only healthcare provider that they have. If you ask the public how often they're getting oral cancer screenings, anywhere from 15 to 25% of the time, people report actually getting an oral cancer exam. Ask hygienists how often they're doing routine oral cancer screenings, only about 25% of the time. And some statistics show that it might even be lower for dentists, that maybe 14% of the time. So again, if it's not you checking, who else is? You might be the only healthcare provider that they have. The Oral Cancer Foundation has a great website. They have a section called the State of Science. They have all kinds of great statistics and articles there. But, studies are showing that providers are reluctant to screen if they don't have really good training on how to screen, and that many people still don't understand the importance of catching things at its earliest rate. Oral cancer can be deadly if it's caught in its late stages. And physicians are delaying diagnosis. Unfortunately, they're not experts in the mouth, so they look there and they may think that some of these lesions are actually things like trauma, infections, or inflammation. I do want to reiterate that it's really important for us, whatever role you play in the dental office, to provide the standard of care. The American Dental Association and the American Dental Hygienists Association both have standards for clinical practice that absolutely recommend that we obtain updated medical, social, and dental history and perform intraoral and extraoral comprehensive visual and tactile examinations on all of our patients. And I think it's just important to remind dental hygienists that we don't have to make the diagnosis. It is our job to identify things that don't look right, to measure, to describe, to communicate, to tell the patient that we're doing, and be part of a healthcare team. Our job is to do the oral cancer screening every single time if we can, intraoral and extraoral. And we want to make sure that we are doing that tactile examination and looking at all those lymph nodes that go from right in front of the ear to behind the ear to behind the head, all the way down the neck to right on top of that deep cervical chain above the clavicle. So dental practitioners, we know we're already trained to know the signs and symptoms of cancer or lesions, the high risk factors in common sites. So it's really important for us to make sure that we're performing these visual and tactile examinations, and that we also are recommending self-screening at home. And this is where the new trend is. And here is our video. And it might just take a minute to load. All right, I'm not seeing the video to load here. So I'm going to just, okay.
Let's just see.
Awesome. be patient. I'm not really good at that.
There you go.
There you go. Thank you.
Hi, my name is Eva Grazel. Now, I know that every month I should be doing a self-breast exam. My husband should be doing a prostate exam. I should be looking at my skin for irregular bumps. But my question for you is, do you know your mouth? I am a stage 4 tongue cancer survivor. I know, crazy. I never smoked in my life. But I'm here to tell you that every time you go to the dentist, you should have an oral cancer screening. Now, you may be getting it. That's when the dentist pulls your tongue out with a gauze. It's a little uncomfortable. They flip it around looking for any lumps, bumps, irregularities. They should flip your lips out, feel in your cheeks. They should ask you to go to check symmetry at the back of your throat. And they should palpate your neck, feel your neck for any enlarged lymph nodes. This is very important. If I had gotten a thorough oral cancer screening and my dentists had the skills to recognize early stages of oral cancer, I would have never gone through what I did. Know the early signs of oral cancer. Visit sixstepscreening.org. Thanks for listening.
I just want to point this out. I like to play this video because I've met her. We've spoken at the same event numerous times. And I want to say that there is a big PR campaign going on right now to educate the public that this is what they should be demanding and expecting when they go into the dental practice. First of all, it's the right thing to do, but how disappointing would it be for a patient to be coming in expecting to get this oral cancer screening, and then not getting it. So this is one of the new trends that we can actually provide this comprehensive visual and tactile examination, but we can also encourage our patients to do monthly self-exams at home, empower the patient to be a partner in this whole, healthcare appointment. And we can go ahead and play this next video. Now, wouldn't it be amazing, if patients were screening themselves at home for oral cancer, for gum disease, for tooth decay, for airway issues? I think it is time to empower patients to start to look inside of their mouth. We do not have to be the only person that's looking in there. I also think it's exciting that still in 2020, we're still learning about new body parts. We're still learning more about medical, dental, oral systemic links. In fact, in 2020, one of the really cool things, the COVID shutdown, is scientists discovered a whole new set of salivary glands we never even knew that that we had. This is going to be really, really pivotal in the treatment of oral cancer, because traditionally, salivary glands get hammered from radiation, but now that experts know that there's this new set of glands, now they're trying to target radiation therapies to keep those intact or to minimize damage, because these burial salivary glands, are the new discovery, are actually responsible for moisturizing the back of the throat. So maybe we won't see xerostomia as being such a huge problem after treatment of oral cancer. Assessment tools are really, really important. Lighting, a camera, something to take measurements with, a ruler of some sort, magnification, and even tools like teledentistry. I love this throat scope. You can buy it on Amazon. You can have it in your office to use, or you can send these home with patients to help them use for their self-assessment. And it's basically a tongue depressor that's lighted, like a lighted tongue depressor. I also love the use of photography. Intraoral cameras are your best friend. Whether it's restorations or decay or perio or airway issues or oral pathology, having this at the tip of our fingers while we're doing our oral cancer exam allows us to capture a whole host of things in this really quick, couple minute exam. I love these types of probes when I'm measuring oral pathology or lesions, or I want something to show up really, really great in an intraoral photo. These color-coded probes here, this one is specifically the ParaWise by Premier. I just love the color coding, and the colors really, really stand out next to tissues. So making sure you have some sort of a ruler, doesn't matter what kind of a measurement device you have, is important to collect really good, accurate measurements. And the measurements, the photos, the documentation, using the proper medical terminology, these are all to kind of help us, play this critical role as a teammate in looking at oral pathology. Adjuncts like tissue staining, brush biopsies, light detection devices, illumination, and magnification are really helpful adjuncts. I actually use the Bellscope on all of my patients, but that is, again, just an adjunct in addition to your comprehensive visual and tactile examination. And the ADA does have a statement on the use of adjuncts that they are great, and we have some really good ones listed here, but they should only be used as adjuncts in addition to looking with your eyes and feeling with your fingers. This is a really great policy statement from the American Dental Association that I love, and this is the new standard of care. For patients seeking care for suspicious lesions, immediate performance of a biopsy or referral to a specialist remains the single most important recommendation for clinical practice. So no longer is considered the norm to wait and watch and let's check it next time. That is not considered the standard of care anymore. We want to intervene as early as possible if something doesn't look right. And then dental hygienists also play a pretty critical role in this quality of life. Say we identify a lesion, we communicate, we document, we refer, it turns out to be cancer. It is important for hygienists to take classes of their knowledge on helping counsel patients through the quality of life before, during, and after cancer treatment with eating, chewing, and swallowing. When it comes to common oral cancer locations, these have not changed. It's still the back of the throat, the sides of the tongue, and underneath the tongue. And the warning signs are pretty much the same. If there's any big sudden changes in voice, changes in how appliances fit, swellings, frequent clearing of the throat, feeling like something's always stuck in the throat, it's a huge red flag now. Trouble chewing or opening, closing the mouth, that bleed easy, red, white, or black patches, something that doesn't heal within 2 weeks, ear pain, or lumps anywhere in the neck, as well as numbness, burning sensation, difficulty speaking, chewing, swallowing, or repeated bleeding in the same area. So, describing lesions is super important to help us differentiate, to triage, and determine urgency and next steps. So this is kind of my little cheat sheet here. What do you see? Where do you see it? When did it appear? Has there been any changes? And what are the potential reasons? Changes in diet or habits or medications or systemic health. What, where, why, and when. This is a really just great kind of sheet for if you go to work, tomorrow and you see something. For what? What size is it? What shape is it? What color? What's the consistency? What's the texture? Again, this is where I like to really take very specific measurements, but if you don't have a measuring tool, estimate the size of the lesion. That's okay. I like to have as much detail as possible, but there is no oral pathology police that are going to arrest you if you don't have exact Measurements are important, and an accurate one is important, but if you can't take an accurate one, try to estimate it. And then use as many descriptors as you possibly can. Think about trying to use your words to paint a picture of what you see so the patient will understand, the doctor will understand, and the referring partner will understand, and you don't even have to be in the room, right? So you can use other examples like ovoid, round, or scalloped, or square, or triangular, or moon-shaped, whatever seems to make sense to you, use those words. And then edges, describing the edges and borders is really important, and this is really important for urgency. Well-defined lesions, where there's very, very sharp, clear outline, those are easily identified. Ill-defined ones mean the borders are hard to see. It's a very diffuse lesion. This is important. Tissues and abnormal tissues kind of merge together, and these types of lesions are typically more concerning. And then if we look at lesions radiographs, we can use the word corrugated to kind of help it describe it, and that's usually seen with a more well-defined lesion. So as we look more at how to describe what we're seeing, we can describe lesions as above the surface, below the surface, or even or flat with the surface, like we started out with the rash was flat with the surface. Now let's kind of look at lesions above the surface. Lesions above the surface can be described in a couple different ways. A blister are lesions that are less than 5 millimeters. A bulla is a lesion that's more than 5 millimeters. If it's between 5 millimeters and 10 millimeters, it's a papule. If it's greater than 10 millimeters, it's called a plaque. And then pustules are inflamed, pus-filled, blister-like sores or lesions on the surface. We know them typically as acne, right? But those can also present in the oral cavity. Lesions that are flat with the surface are kind of like freckles, but are also described by their size. A macule is less than 10 millimeters, and a patch is greater than 10 millimeters. And examples of these lesions are even with the surface are things like freckles or Mongolian spots. Red macules and patches can also be described based on their size. Little tiny red patches are petechiae, little larger are purpuras, and then larger ones are ecchymosis. And then there's lesions below the surface where maybe we feel it, but we can't necessarily see it. These are nodules, and nodules are growth of abnormal tissue beneath the surface. We also are very familiar with lesions beneath the surface, like abscesses and different types of cysts. Hematomas are bleeding and swelling beneath the tissues, and they can be caused by a wide variety of things and usually have that bluish kind of hint. Trauma, injury, dental treatment, injection sites, or even Botox. If you are looking for some great cheat sheets, I would encourage you to go to Twitter or Pinterest and just Google like skin lesion reference guides. And there's all really great ones. I print out these and I put them in my operatory. So I don't always have to remember those sizes. But here, this one tells you, a papule, plaques, fistula, vesicles. It gives you a little description and also gives you a little cheat sheet on the size. Primary lesions, macules, nodules, pustules, plaque, vesicles, these are all primary. Actually, burst and ooze and scab and scale and scar, they're then considered secondary lesions. Describing where lesions are at based on location and distribution. Location should be as specific as possible. Maxillary, mandibular, hard tissue, soft tissue, palate, cheeks, tongue, lips, near the apex of a tooth, near the midline of the mouth. Being as specific as possible. Anterior, posterior, inferior, superior are all really good clarifying terms. And then distribution, is it localized, is it generalized, is it unilateral? How many lesions? Is it multiple lesions? Or you can even list the specific number of lesions. And try to use anatomical landmarks whenever possible. We can use teeth, we can use nerves, we can use sinuses, we can use bone, we can use tissue like keratinized, non-keratinized. And then we, of course, know how to describe radiology with radiopaque, radiolucent, and mixed density. Mixed is when we have more like that cotton peel or cotton or orange peel kind of texture. And then when we're looking at, why is it there and when did it appear? This is where this comprehensive evaluation and updated medical social history is really important. And most likely we're going to have to ask really probing questions about trauma, habits, diet, lifestyle. I do a whole course on vaping and new trends like kratom and tobacco pouches and things like that. And I've learned that we have to be using the really new, current, relevant terminology. If you ask somebody, a younger person, for instance, if they smoke, they'll say no. If you ask them if they vape, they will say no. If you ask them if they juul, they will say yes, because that's a very specific brand of vaping that's very popular. So, we have to ask pretty deep, probing questions, and sometimes lots of questions to really get to the answers. Reviewing, charting notes from the past, really collecting as much data as we can to help establish a timeline. And I'm not going to spend any time on skin lesions, but the whole conversation today, I'm talking about intraoral lesions typically are around the mouth, but we really, during that visual and tactile examination, should be checking the whole entire head and neck and hands, or any skin that you can possibly see. According to research, several articles that I came across, these are the 6 most common oral lesions or pathology that dental hygienists are probably going to come across: candidiasis, herpes, recurrent aphthous-stomatitis, erythema migrans, hairy tongue, and lichen planus. So recognizing these clinical characteristics, kind of some prevalence, demographics, are really, really important to kind of see if it fits into one of these kind of categories. We know that candidiasis is a fungal infection. It's an opportunistic type infection. So typically when somebody becomes immune compromised, they're at high risk for fungal infections. But other risk factors are smoking, xerostomia, which almost everybody in the planet has mouth now, I've determined. Dentures, diabetes. It can be uncomfortable or it can be asymptomatic. And many biopsies are actually showing that some of these, fungal infections aren't just candidiasis, but they're combo infections of candidiasis and bacteria, like some of those periodontal pathogens, or candidiasis and things like staph bacteria, bacterial, viral, cross-kingdom infections. In fact, most of us, 60% of healthy adults, actually do carry some form of candida in our mouths. But when it becomes a problem is when there's overgrowth, right? So when the mouth is dry, inhalers, endocrine disorders, malnutrition as we get older, radiation therapy, things like that make us much more susceptible. And the risk of a systemic infection is pretty high. Fungal infections can be maybe a little bit more innocent in the mouth if somebody's healthy, but if somebody has diabetes, if they've recently been hospitalized, if they've had an organ transplant or were born premature, these mouth infections can actually be systemic and cause candidiasis in the whole body. And there's 2 different types of candidiasis infections. There's pseudomembranous, which is that white plaque that may wipe off, and then the red form, the red macular lesions that are typically sore, they might burn. An example of this is the median rhomboiditis. That's that, redness in the middle of the tongue. This is a very common manifestation of some chronic kind of fungal infections. The texture will be smooth, the loss of the filiform papilla. And then leukodema is another manifestation of a candida infection. It's very, very common. And these are more like the white creamy patches that don't wipe off. And then herpes, we see this all the time in private practice, right? Or hear about it from our patients, or maybe even experience it ourselves, but it's typically a recurrent infection. This is one of those viruses like I was talking about with HPV. You get exposed, you have an infection, maybe you don't, maybe you know, maybe you don't know, maybe you had an outbreak, maybe you didn't, but this goes dormant in the trigeminal nerve. And that's why when it gets reactivated, we typically have lesions around the mouth. We do know that about 15 to 45% of the population does get cold sores. There's those common triggers like ultraviolet light, trauma, fatigue, stress, even some research saying around menstruation. Well-clustered vesicles, pain can be swelling and be significant. Oral antivirals, topical dentivir, and systemic antivirals should be considered for only immune compromised patients. And these are what some of the manifestations of these viruses look like. Recurring aphthous-stomatitis, these are ulcers surrounded by this yellowish white pseudomembrane and a red halo. So red halo, kind of a key indicator here. Chlorhexidine actually sometimes can be helpful in the management, but with steroids and antifungals and chlorhexidine, there isn't a really heavy evidence-based body of research to show that these things actually help. But it's estimated about 5 to 21% of the population will get recurring aphthous-stomatitis. There's some skepticism on whether it actually is a vitamin deficiency or not, but 22 different viruses have been actually linked to recurrent ulcerations, as well as irritable bowel syndrome, celiac disease, HIV, and other viral infections. And there's 3 clinical forms: the minor ulcers, the major, and then the herpetiform. But basically, an ulceration is a break in the mucous membrane or the epithelium. It could be caused by viruses. It could be caused by abrasion. It could be caused by medications or change in the pH in the mouth. It's estimated that about 15 to 30% of the population will experience ulcerations at some point. Women are typically a little bit more susceptible than men. The minor ones, they can be painful. They last 7 to 10 days. They're in clusters. They're less than 1 centimeter. If they're larger than 1 centimeter, it typically is going to be classified as major, and these last much longer. They could even last up to 6 weeks. Beckett's syndrome, I like to mention if somebody gets recurrent aphthous ulcers, but also have this co-occurring conjunctivitis, problems with their eyes, they actually could have a syndrome called Beckett's syndrome. So when you're looking at ulcerations, it's important to ask people about other body parts and if they're getting any sort of lesions or sores in other things like their eyes or their ears, or their hands or their armpits or their body or their trunk, to determine if it is just an oral manifestation or if it might be something else. Erythema migrans comes and goes, unidentified cause, migrating lesions, central redness surrounded by white to yellow elevated borders, typically on the tongue. About 1 to 3% of the population will experience this, usually on the top of the tongue or the side. You also might know this as geographic tongue. Geographic tongue, there's about 3% of cases are genetic. There is a high likelihood that people who have autoimmune diseases or autoimmune psoriasis or certain types of arthritis may be predisposed to geographic tongue. But some studies show that stress, hormones, vitamin deficiencies, and other, systemic issues might actually trigger this reaction as well. It could be painful or not. It could be red, it could be white, it could be yellowish, but it's a disruption in the papilla. Sometimes antihistamines will help if there is some discomfort. But geographic tongue could be hormonal, it could be mental, it could be genetic, it could be nutritional. And studies are showing that there also might be cross-kingdom interactions here, that there might be also bacteria and fungal colonization in some of these cycles. Hairy tongue, this is the elongation of the papilla on the tongue. It's very common in people who smoke. When we look at hairy leukoplakia, very commonly associated with other viruses, Epstein-Barr, mono, and HIV. I think we're going to see a lot of articles and CE courses on Epstein-Barr virus coming out because we're learning a lot about that. So I would watch for that in future courses. Oral lichen planus, is a chronic inflammatory disease. It affects only about 1 to 2% of the population. And there's 2 different kinds. There's the reticular, which is the lacy white patches, and then there's the erosive, which is the red patches, which could be very, very red, inflamed, and ulcerated gingiva, and typically that responds best to topical corticosteroid. So lichen planus is considered an increased risk of cancer. It typically has some pain or burning sensation associated with it. If people say they're really sensitive to spicy foods, they could be experiencing lichen planus. There could be thick patches on the tongue, and there also could be lesions in other parts of the body, like the ears and the genitals. Lesions caused by biological agents like anthrax and Ebola actually have oral manifestations. There's lesions caused by bacteria and viruses. We've already talked about the aphthous and the herpes, but things like syphilis also has an oral manifestation. There's lesions caused by physical irritants. Is there a denture or an appliance or a prosthetic that's, rubbing? We have amalgam tattoos, lesions from radiation overdose, basically just super angry, inflamed mucosa. And we could also have lesions associated with things like oral piercings and tongue splitting. We're seeing all kinds of crazy trends in the oral cavity, right? What used to be kind of amalgam to the tattoos in the mouth or amalgam tattoos, now we actually have tattoo sayings inside of the lip, and we have really interesting new crown and bridge and veneers things that actually could maybe be providing some roughness, irritating tissues. And it is important that if your patients do have, that we are assessing the health of the oral piercing, right? We're obviously concerned about chipped teeth and things like that, but most importantly, we know if there's redness, if there's oozing, if there is crusting, looking for some of these classic manifestations that we know are signs of inflammation. We would want to counsel the patient that could be considered a risk factor for oral cancer, chronic irritation. I always like to try to be up to date on what's going on with tattoos and trends and piercings and things. So if you want to, again, go to Pinterest or Twitter, you can find out all the names of all of the new piercings and things that seem to still just be coming out. I'm learning new things about trends every day. In fact, this is the newest thing that I came across is tongue splitting. So tongue splitting's been around for a while. However, I did not know that there's multiple ways that people could split their tongue. There is a scalpel, which was kind of the first way. Now that's kind of evolved into laser. And the newest trend is actually using fishing line. So you can imagine that if somebody is going into a place and having their tongue split with fishing line, there could be an increased risk of, trauma, contamination, infection control, all kinds of different problems with healing. So, I think it's good to, again, ask questions if somebody comes in with their tongue split, like how long does it look like this? Do you have pain? How is it done? And document what you're seeing. When I see them a little freaked out that looks weird, but then I have to go into my science brain. Well, then how healthy does it look? Chemical irritants, we can have burns, nicotine, stomatitis, irritated taste buds. Drugs obviously can really, wreak havoc on the oral cavity from constant trauma, gingival hyperplasia. You know that hormones can also create a lot of changes inside the oral cavity as well. Everything from pyogenic granulomas to pregnancy tumors to puberty enlargement. Hormones are just out of control. We have growth and development issues, with teeth being fused together, teeth splitting, the size and shape of teeth. We should be documenting all of this in the patient chart too, as far as growth and development. And then we have I was trying to turn here. Then we have things like microdontia, neonatal teeth being present at birth, supernumerary teeth. These are all things that we would want to be documenting during this oral cancer exam and watching these things for pathology. Tori, palatal, lingual, where is it? Is it bilateral? Is it mild, moderate, severe? Exostosis, is it anterior? Is it posterior? Bilateral, unilateral, mild, moderate, severe. Fordyce granules are another thing that we could be documenting during this oral cancer exam. And looking for tongue ties. I was sharing with my colleague here when we started about how important it is for us to checking for growth and development of airways. One of those, are you screening your patients for tongue ties? When we kind of go into more, serious pathology, though, nobody likes to hear the C word. And when we look at cancer, there's squamous cell carcinoma. We have the malignant, which is cancer of the squamous epithelium. And then we have the benign changes to the squamous epithelium called papillomas. Basal cell carcinoma is the most common type of skin cancer, and it's typically seen on the nose, but we can also see basal cell carcinoma in the oral cavity. And this is basically cancer of the cells that are responsible for new tissue turnover. When we look at papillomas, they can be, the corner of the mouth, side of the tongue. They can be in the back of the throat. Typically, papillomas are considered benign lesions of the squamous epithelium that can progress into carcinomas. And fibromas are benign tumors of connective tissue cells. So papilloma is squamous epithelium, and fibromas is the connective tissue. And then we have, really serious manifestations like this, which accounts for about 5% of all oral cancers, and that's where we see that cauliflower-like squamous cell carcinoma. And this is typically a lot of times on the side of the tongue and very closely associated with high risk like chronic irritation, HPV, and smoking. Looking at other kind of HIV, AIDS-related lesions, these are kind of ones that we were all taught: hairy leukoplakia, candida infections, and recurrent red and white lesions are all very common in late stages, HIV and AIDS, not typically in the early stages. Some just kind of medical terminology recap and refresh. Lipomas are benign tumors of fat. Adenomas are tumors of salivary glands. Osteomas are tumors of bones. We have rhabdomyoma, tumors of muscles. Papillomas, the tumors of squamous epithelium. The carcinomas is the malignant tumors of epithelium. The sarcomas is the malignant tumor of connective tissue. And then melanoma is the malignant tumor of melanocytes. We also know that the salivary glands could also develop different types of tumors. When we look at different types of cyst tumors of the salivary glands, the mucoceles are the blockage and inflammation of the tiny minute salivary glands, and then the ranulas are bigger salivary glands. This is a picture, really great x-ray of a salivary stone. It's a calcified mass or stone in the blocked salivary gland. Lipomas are basically just tumors of fat. We have the common mole on the lip is called a melanocytic nevus. It's the common mole. It's considered typically a benign tumor of melanocytes, but whenever I see this, I always recommend somebody to a dermatologist to have it monitored. Melanoma can actually also affect the skin, but also the oral cavity, and especially on the lip. Lip melanoma typically affects that surface cells of the skin. So anytime that there's a lesion that constantly bleeds, that constantly crusts over, that would be something to recommend have checked out. And then we have, these types of lesions that are associated with sun exposure, fair-skinned, these pale crusted fissures of cheilitis. Mucous membrane pemphigoid. This is very, very rare. Autoimmune blistering lesions that affect the various mucous membranes of the eyes and the mouth and can be very, very painful. Hopefully we've gotten through this horrible pandemic, right? Hopefully we're coming out, but we do know that COVID was basically a disease of small capillary vessels. So there's a condition called COVID toes, meaning people would have these bluish, purplish toes, or fingers, meaning there was damage to all the tiny little capillaries at the surface. Well, the same thing can happen in the tongue and manifest in a condition called COVID tongue. Red or white bumps, burning or no pain, inflammation, discoloration, possibly lack of taste. But we know with the lack of taste and smell, other symptoms of COVID were things like dry mouth, or on the opposite end of the spectrum, excessive saliva, rashes in the mouth, ulcers, angular cheilitis, and bad breath. We also have a really good body of evidence to show that the periodontal pocket is actually a reservoir for COVID-19. Viruses will stay in that reservoir, just like they stay in fat cells. I think this is important because as we talk about other viruses down the road, they probably are going to harbor themselves in the same places that COVID did. So oral manifestations of COVID was typically the tongue, labial mucosa, the palate, the gingival, and very rarely buccal mucosa in the back of the throat. Some common manifestations of COVID: rashes on the skin, rashes inside the mouth, recurrent aphthous ulcerations, different red-like ulcerative lesions, and then, the cheilitis in the corners of the mouth. Other manifestations of COVID were like purpley lesions, either on the lips or on the sides of the tongue, inflamed papilla on the tongue, necrotizing periodontal disease, or just really angry mucosa. Some people also reported reports of burning sensation or burning mouth syndrome. Some people had a ton of saliva. You think about how inflamed the respiratory system was. Nose is running, eyes are running, mouth was running, and then there was even reports of spontaneous tooth loss. Well, if you think about tiny damage to the vessels, right, tiny damage, microcapillary damage, well, the whole periodontal ligament, everything that's holding the tooth in, is a very rich, big blood supply. So if there's damage to the blood vessels that are in the periodontal ligament, that is what's being attributed to spontaneous tooth loss. Dry mouth, dehydration. Many people had coping mechanisms during COVID with alcohol and drugs and other things to redress. Vapor's tongue is basically just when all of the taste buds get coated with the oils. Vaping is almost always a dry herb or an oil that clogs the taste buds. It means the taste buds can't receive signal. They get so clogged that they actually die off. And that all manifests typically in very enlarged papilla on the sides of the tongue, and sometimes they may even be obtained from different types of tobacco. Nicotine pouches are kind of the newest craze right now. They're pouches that go down into the vestibule. They've really taken the place of chewing tobacco, and they also can leave some of the same residual type lesions that old-fashioned chewing tobacco did. So for many years, I didn't see these leukoplakias, but now in just the last couple of weeks, I've seen a whole bunch of them. Many young people are using these tobacco pouches thinking that they're safe, but they're still causing tissue irritation and still may lead to leukoplakias. Radiolucencies and radiopacities, believe it or not, are usually pretty rare. They could develop in bone or tissue, and they're usually non-cancerous. If you want to describe a radiographic lesion, one of the best ways is actually use the word lesion. Location, edge, shape and size, the makeup of it, our other structures, and the number of them. And this is where we would use this corrugated. Is a lesion well-defined or ill-defined? And then is it corrugated? Is there this little thin radiopaque outline surrounding the lesion that's often seen with cysts? We're almost done. I just have a couple quiz questions for you guys, and we're getting towards the end. Again, if you want to remember your landmarks, you can go to all these great Google sites and refresh your landmarks. But a tumor is an abnormal growth or mass of tissue, and cyst typically contains liquid or a semi-solid material. Odontogenic cysts originate from cells and tissues that are involved in normal tooth development, and non-odontic ones develop other tissues within the jaws, and they're not really related to teeth. When we look at odontogenic cysts, the most common one is typically periapical cyst, right? The abscess. But in the second place is the dentigerous cyst, and these contain air and fluid and maybe other semi-solid material. Which of the following cysts can be identified by a heart-shaped lesion on a radiographic examination, and which of the following cysts can be identified by a pear-shaped lesion during your radiographic examination? Nasopalatine canal cyst, labiomaxillary cyst, or a simple bone cyst. The nasopalatine cyst is the heart-shaped one that's inside the papilla area. Commonly between people ages of 40 to 60, it typically is asymptomatic, a little more prevalent in males. Well-defined lesion, usually in that Y-shaped nasopalatine canal, and often manifest in a heart-shaped lesion. The pear one is the globiomaxillary. It's well-defined, it's radiolucent, and it typically is around in between the lateral and the cuspid. And then the simple bone cyst is the traumatic cyst. It is a result of trauma, and it typically has the scalloping around the root. Other jaw diseases that we're not going to talk about that are important in your examination is a full evaluation of the TMJ and parafunctional habits like clenching and grinding. And then again, kind of looking at, the mouth and the rest of the body. I just always talk about nevoid basal cell carcinoma syndrome because there are tissue lesions on the skin as well as radiographic lesions on the x-rays, and these go hand in hand. And it manifests as a development of multiple cysts within the jaws and multiple basal cell skin cancers hand in hand. Dentigerous cysts are those that are typically around erupting third molars. Fluid-filled sacs that develops in the jawbone and around soft tissue, it's typically fluid-filled, and typically, in the ages of 20 and 30 around erupting or impacted third molars. And then ameloblastoma, the important thing to remember here is they're like honeycomb or bubble-like, and they typically are in the mandible. About 80% of them are in the mandible, and typically kind of right at the ramus. They're typically benign, and they typically occur between males between the ages of 30 and 50. The radicular cysts are painless at first, but once infection develops, then there's typically pain. These can develop initially in the periodontal ligament. So diagnosis of tumors and cysts is we cannot tell by just looking at something. There has to be imaging and advanced imaging. There has to be biopsies and typically removal, lab analysis of the tissues, and lab analysis of blood work of the individual. These are just some of the images that I work with on a daily basis as an airway provider, capturing tongue ties on a CAT scan over here. On the bottom, this is what a tongue tie looks like on a CBCT scan. Right here, this dark area, that should be filled with the tongue. It's not. This is what the tongue tie looks in real life. This is a deviated septum here. You'll see the septum veers off. So we have one larger nostril and one smaller nostril. Look at the picture. You can tell by looking at people's noses We look up people's noses all day long. We can tell typically by looking at somebody's nose if there's a deviated septum. And then look at this one. Look at these huge tonsils right here. This is what the tonsils, enlarged look like on a CBCT. So our imaging and our skill sets are becoming much, much more complicated and more in depth. And I think it's a really exciting opportunity for us. So, your job is just to have a quick refresher, just remember what's out there and how important it is to know the what, the where, the why, and the when. Tell your patient what you're doing. Inform them that you're doing an oral cancer screening. Document, take photos, capture lesions and descriptors as you possibly can. And then looking at products to help your patients. I'm a big advocate of stannous fluoride. It's the only one that's anti-caries, anti-sensitivity, and anti-gingivitis. I like to promote multi-use products whenever I can, so they don't have to use a product for each one of those. So there's products out there that are multi-purpose. I recommend sealants on all of my patients, knowing that high-risk pathogens are in the mouth and they're being linked to pathology like throat cancer. I want to seal up every little nook and cranny I can to prevent those bacteria, from living in this environment. And I want to thank Premier Dental for sponsoring my course tonight. They have some really great innovative products. They have a cordless handpiece that I love, and they actually have a new polishing system for patients called the ISO, and I just want to thank them for sponsoring this course tonight. So that being said, my email is lancettg@gmail.com. My website's Hygienist for Health. And I apologize that I added my monkeypox stuff at the last minute. It was like an extra 5 minutes ago, but I thought it was really important. Please reach out to me after today with questions. We don't have to end the conversation here. I am here as a resource for you. So please reach out afterwards, and I am here to help if we don't get to your question. That being said, I will go here to the Q&A and see what questions are there, and we have a great moderator to help me get through them.
Actually, you can take a breath now, so thank you for that's an incredible program. I didn't think you'd get through all that information.
I had to pack as much in as I can. It might be the only oral path class you take for a couple of years, so.
Yeah. We're definitely going to have you back. So thank you so much for providing all that information. It was wonderful. And, what's interesting is I don't think people could catch up with you on the questions. So we just really have one that says, how often should a patient get a biopsy? Pretty generic,
gosh, yeah.
But what's your comment on that?
Yeah, I have patients that I refer repeatedly for biopsies, and I don't have any legit statistics, but I would typically like the third or fourth time that I've been referring them is when they sometimes come back malignant. As many times as your team feels like it's warranted, right? When I say that we're an advocate for the patient, we want them to live, we want them to have good quality of life. I don't think there's anything wrong with sending them to a specialist, or we don't do biopsies in office. We send ours to a specialist. But there's a lot of things. What's the medical social history? What's the track record? What's the patient temperament? What's the doctor temperament. But I would say many of my patients, I've been a hygienist for 27 years. I'm super loyal. I stay at practices forever. So I have a good track record that the first couple may come back, as nothing, but many times eventually they come back malignant.
Great. And you did give people a chance now to get to their keyboard. So questions are coming in. If you have a few more minutes, that would be great. A question when taking a CBCT, and you probably do that now with your sleep practice as well. Do you put the patient's tongue on the roof of the mouth or have them place it on the roof?
Oh, this is such a good question. We take it at their natural rest posture. For us, we want to know where does their tongue live in a normal state. And I have found when I tell people to try to get them to do things, they do weird things. People are weird. They're not their normal kind of habitat. They overcompensate, and they might do things that they don't normally do. So in our practice, the important thing is a standard protocol. The standard protocol is just their normal rest posture. And that way, no matter who's taking the CBCT, we're all saying the same thing and hopefully have more accurate scan to compare from visit to visit.
Great. Another one from Kaylin. What do you think or look for with a lot of tissue sloughing? What's the first thing that goes through your head?
Well, the first thing I almost always think it's like a habit of a parafunctional habit, clenching or grinding, chewing, nervous habits. I think it's a habit that people don't even know that they have. Chronic irritation is the number one cause of tissue sloughing. People chew on all kinds of things. We don't typically see that, like with tobacco or vaping or drug use. It's pretty much probably a habit of chewing, grinding, sunflower seeds, grinding your teeth, things like that.
Great. And because we're at the hour, I'm going to just give some information, but really, Lancette, if you have a few minutes, we have some more questions, if you're okay with that.
I'm in no hurry whatsoever.
Okay, good. You're in West Coast, so you're a couple hours behind.
I know, it's early at home. It's only 4 here.
So we did record tonight, so you'll get anybody attending tonight will get an email with the recording, and you'll certainly want to go through that recording because so much information was provided. And there is CE tonight, so if you want to get CE, click on the icon on your screen for CE, and we'll get that to you as well. You'll need to complete a survey. And at the end, when you finally log out, you will get a survey about how tonight went. We'd appreciate any feedback. And if you have any feedback for Henry Schein as far as what do you want to hear about the future or areas to improve upon, you can always email us at webinars@henryschein.com. So for those that have to leave, but I'm sure most are sticking on for the answers to these questions, but I appreciate everybody's attention. So now back to the questions. And this one, you could probably talk quite a bit on tonight because of the new passion you have for this area. Why is tongue-tied a problem?
Oh, that's a really good question, too. We know that the tongue has to freely move around the mouth starting from birth. It is vitally important for feeding, whether it's bottle or breast. It's very important to establish nasal breathing. If a tongue is tied, typically that is going to lead to open mouth rest posture, and people are more susceptible to breathe through their mouth. When you breathe through your mouth, you're not getting, nice, warm, filtered out oxygen. So if you breathe through your mouth, you're getting cold, dry, dirty oxygen, which then hammers your tonsils and adenoids. It makes you more susceptible to a whole host of things, from inflammation to infections. So the tongue tie, predominantly in the past was always associated with speech. Now, I think speech is like the least of my concerns. It's actually breathing and sleep. And when the tongue is tied, there's a high correlation of obstructive sleep apnea. When the tongue is tied, it can't suction to the roof of the mouth. It's supposed to live at the roof of the mouth at rest. And when we sleep, if it can't suction to the roof of the mouth, it falls to the back of the throat and obstructs the airway. That's obstructive sleep apnea. In addition to speech, pronouncing certain letters and things like that. But most importantly, it's just because when the tongue is tethered, it interferes with, eating, speech, swallowing, breathing, and is a prime contributing factor of obstructive sleep apnea.
And are you often or always releasing the tongue through laser or surgery?
Nope. We always refer to a myofunctional therapist. So we have about 5 myofunctional therapists, and everybody who has an airway red flag, if it's enlarged tonsils, if it's a tongue tie, if it's a lot of pori, if it's bruxism, if it's recurrent caries or periodontal disease, those are warranted a sleep test and a referral to a myofunctional therapist. Think about when the tongue is tied too, it doesn't have the ability to freely move around. So you don't have the ability to clean off the teeth. So people who are tongue tied are more susceptible to tooth decay and gum disease as well. We always refer to a myofunctional therapist. I don't do myofunctional therapy. I refer to the specialists. They do pretty in-depth consultations, and we always try therapy first. In the cases that need surgery, therapy is really important first, because what I have found out now after working in airway a couple of years is if you don't thoroughly do all the exercises and stretches, you can do the release, and all that fascia will reattach and it will grow back. So tongue ties will grow back, tonsils and adenoids grow back. So surgery isn't always just a quick, easy answer.
Great. Another question on... You mentioned the reservoir of COVID in the pockets. So we have noticed people that had COVID now have deeper pocket depths. Do you think it was because of the pocket being a reservoir?
100%. I mean, I know that there's at least 6 or 7 research articles now talking about people who had COVID infections. If they had deeper pockets, they were more likely to get infected with the virus, and if they had deeper pockets, they were more likely to have complications. Also, fat cells. You know, if you have a little extra weight, you have more reservoirs for the virus to hang out. You know, the virus comes in your body, it replicates, and then it's supposed to kind of die off. But if it has places to hang out, like fat cells or periodontal pockets, it leads to more serious infections, more, you know, symptoms, and longer infections. So we do have a lot of research now on gum disease and COVID.
Yeah. Question on the CBCT again. Do you move the chin forward to arrest on the positioner during CBCT?
We don't try to alter the natural position at all. You know, we have stools and ladders and chairs and things to have them be in whatever their natural posture is. I would tell you most people who have an airway problem have forward head posture. Their chin is already naturally out because that opens up the airway. But neutral posture, we try not to alter their natural state.
If your CBCT has a chin rest, though, where the patient can go forward and rest for stabilization? I think that's the question.
We do have, yeah. Oh, sorry. Yes, you're right. We do have them put their chin on a rest as a stabilizer to minimize movement for sure. Thank you.
Okay. Yeah. And then I think you answered it. I don't know if it was Pinterest or what other social media, but where can I get a cheat sheet for oral lesions? In the description.
Yeah, well, first of all, if you want to email me, I will make you a handout. You can have my presentation if you want. Otherwise, like Pinterest, YouTube, Twitter, you know, you can get cheat sheets for anatomy and physiology, for lesions. Dermatologists that I work with, they've given me some really nice printed materials as well. To just describe lesions, not necessarily, you know, skin lesions. So, you know, reach out to other healthcare providers. I have found other healthcare providers are always willing to help share resources, and dermatologists are great.
Great. Well, you should be very proud. I don't think anybody left, so they were all excited to hear your answers.
Oh, thanks,
and if
guys.
we get any,
I'm so sorry for going on last minute.
No, that's great. And I think I did put up the screen with your email and contact information. So appreciate you being so welcome to the attendees tonight. So I wish everybody get your CE, click on that button, do the survey and get your CE. It's certainly extremely valuable. We'll email you the link for the recording so you can slow motion it and get all that information, all those great slides. So on behalf of Henry Schein and Premier Dental, Lancette, thank you so much for what a wonderful presentation tonight. We look forward to having you back, and thank all of you for your attendance tonight. Have a wonderful evening.
Thanks, guys. Have a good week. Bye-bye.